really exciting. This is our first CPMH seminar of the year, which is wonderful. So special thanks to Tandy for organizing. As many of you know, our CPMH is a collaboration between us here at Department of Psychiatry and Mental Health and the Department of Psychology at Stellenbosch University. So it's really great to have you all here today. So our speaker today is Julia, and she's a doctoral student in psychiatry and is a researcher for the study of African economics at the University of Oxford. And she was here for a few months earlier this year, and now she's back in Oxford in the cold. So it's really great to have you here. Her background is in economics, and it's a focus on development economics. Her main interest is on the relationship between depression, poverty, and risk behaviors amongst adolescents in low middle income countries. And along her DPhil, she does collaborate with multidisciplinary group, which makes sense because you're also talking to a multidisciplinary group here in a number of low and middle income countries. And she's been focusing on working with psychologists, psychiatrists, neurosciences, and developmental economists to develop a digital intervention for adolescents with depression living in low resource settings. We're really excited to have you here, Julia. I will pass on to you. And at the end, if any of you have questions, you can put in the chat. We'll try to watch the chat as we go, and we'll have a nice discussion at the end. So welcome.
Great. Thanks so much, Catherine, for the introduction. And thanks everyone for being here. Let me share my screen. There you go. Just confirming that you see the screen okay?
Yeah, I can see it perfectly.
Great. So as Catherine was mentioning, I was very lucky that Crick invited me over for 10 weeks early this year. So it's just really very nice to reconnect with everyone and see familiar names and faces. So thanks so much for having me, and thanks everyone for being in the audience and listening. So as Catherine was mentioning, I'm Julia, and I'm in the final year of my PhD in psychiatry here at the University of Oxford. And the overarching topic of my DPhil is looking at the relationship between depression and risky behaviors among adolescents living in low and middle income countries. And 4.5 years ago or so, I started working with Alan Stein here at Oxford, and really a very large multidisciplinary team on a study that was looking at adolescent mental health. And so as someone with a background in economics, I started reading on the very large effects that depression has, not only on health and clinical outcomes, but also on economic outcomes. So things like how much someone invests in their own education, lifetime earnings. And so this really led me to start creating a research agenda that could bridge the gap between psychiatry and economics. And so in this 40 minutes, they asked me to talk, and I hope that there will be some discussion later on. What I really want to give you is some background on the context, on why is it important to focus on depression and risky behaviors. And then I'll present some of the key findings of the studies that I've conducted so far as part of my PhD. So why depression? So I don't have to convince you. I know that if you're part of the seminars because you are interested already and know about the very large impacts that depression has. So we know that depression is a leading cause of disability worldwide. And it's estimated that more than 280 million people are affected at any moment globally. And so this world map shows the number of people of all ages and sexes with depressive disorders by country in 2019. And then we know that untreated depression in turn can have very serious consequences for the individual, but also for their families and society as a whole. So depression, for example, has been linked to poor health and poor economic outcomes. So for example, lower levels of education, worse employment opportunities, and poverty. And then on the other hand, risky behaviors such as drug use or unsafe sex can also result in negative life outcomes. So things like, for example, substance abuse, sexually transmitted diseases, and in the worst case, premature death. And they can also have very large costs for society. And so risky behaviors are really major sources of preventable deaths. So the graph here on the right shows the total number of deaths that are attributed to specific risk factors. And I've highlighted some of them. So you see that risk factors such as smoking, alcohol use, unsafe sex really kill millions of people every year. And then we know that adolescence is a period of opportunities. So we know that there's many changes that happen during this time. So there's biological changes, cognitive changes, social changes. It is a time when the adolescents start to develop their own self-identity, and they start making very important life decisions on where to go to school, entrance into the labor market, sexual relationships. And so while it is a period of opportunities, it is also a time of vulnerabilities. So it's a time when the incidence of depression peaks. So here in the graph, I show you the prevalence of major depressive episodes by age, and this is using data from the US. And so you see from the very left bar, 12-year-olds, and you see that around 5% of them suffered a major depressive episode at that age. And then from then on, you see a big increase in the prevalence, peaking at 18.5% with 17 years old, and then lower prevalence for the older age groups. And then it's also, adolescence is also a time of vulnerabilities because many of these risky behaviors that I was mentioning before begin to emerge during this time. And this is particularly the case when adolescents are with peers. And so really the combination of depression and risky behaviors can result in a negative spiral and in really further psychological and physical health problems that can persist across the lifespan. And most of the studies that have explored this association have explored this in using data from high-income countries, which makes it very difficult to generalize to low and middle-income countries. And because we know that most of the world's adolescents live in low and middle-income countries. And so given the large treatment gap that we know is present here in these settings and the lack of, in general, social safety nets, many adolescents live in places where the combination of depression and risky behaviors can really result in particularly poor living conditions. So that's the context on why I think it's important and where the gap in the literature is. Which then brings me to the objectives of my thesis. So I will first outline what the objectives are, and then I will talk about the empirical studies within each of these objectives. So objective number one of my thesis is to examine predictors and correlates of depression among adolescents living in low resource settings. So this includes things like looking at risk factors for depression, but also looking at the association, for example, of depression with socioeconomic outcomes. I then move on and start exploring the relationship between depression and risky behaviors as part of my objective number two. As part of objective number three, I move beyond questions of associations and I start examining possible mediators and moderators in the relationship between depression and risky behaviors. And then finally, in objective number four of my thesis, I bring all of the evidence together from the previous objectives and start exploring possible interventions that one could do targeting depression and risky behaviors. So those are the four objectives. So let me walk you through the empirical studies within each of these objectives. So in study one of my thesis, I used data from a large cohort study of adolescents in rural South Africa, and I studied the risk and protective factors for depression. And I'll talk more about this in the next section. In study two of my thesis, I used data from a nationally representative sample of refugees living in Uganda, Kenya, and Ethiopia. And I look at the association between depressive symptoms and socioeconomic outcomes. So things like employment status and income. In study three, I conducted a systematic review and meta-analysis to look at the effect of depressive symptoms on risky behaviors. And then the relationship between depression and risky behaviors could well be that bidirectional. So it could actually run in both directions. So from depression to risky behaviors, but it could also be that it runs from risky behaviors to depression. So this is what I explore in study 4 of my thesis. So I use a large nationally representative cohort study of South Africa, so the NEET study, and I look whether there's any bidirectional relationship between depression and risky behaviors. And I also look at whether this relationship differs by the type of risky behavior and individual characteristics. And then one factor that may play an important role in this association is executive function, which is often an umbrella term used to describe higher level cognitive processes that allow us to control and coordinate our own thoughts and behaviors. And so the evidence from high income countries shows that depression affects an individual's ability to exercise executive function. So if, for example, it makes it harder to take the time to think before acting or to resist temptations. And so these deficits in executive function in turn do predict engagement in risky behaviors. So taken together, this suggests that executive function could be a mediator in the relationship between depression and risky behaviors. But this relationship has actually not been explored in a low and middle income country context. So that's what I look at the study in study number 5 of my thesis, using a cohort study of adolescents in South Africa that has data it has basically a comprehensive battery of executive function tasks that was implemented. And then finally, the last study of my thesis describes the design and development of a digital mental health intervention that I've been working on for the past 4.5 years. And I spent some time in South Africa and in Uganda doing the formative work to co-construct the intervention with adolescents. And in this talk, I'll discuss basically key findings from study number 1 and study number 3. And then I'll briefly mention some of the highlights from study 6, which is actually, we're currently testing the feasibility and acceptability of the intervention in South Africa and in Uganda. So I'll briefly go through those 3 studies. And if you have any questions, please do interrupt. I'll try to manage with the screening and the chat. Do ask questions. Great. So study number 1 looks at the following research question. What are the risk factors for depressive symptoms among adolescents living in low and middle income countries? And why do this study? Let me just admit Diane. There you go. So why do this study? So first, because we know that some of the risk factors for depression, such as poverty or exposure to violence, are overrepresented in many of these low resource settings. And so this makes adolescents living in this context much more vulnerable to depression. Second, because much of what we know about risk factors for depression in low resource settings comes from cross-sectional studies. So you can't really establish any temporal relationship between first being exposed to the risk factor and developing depression later on. So using cohort studies to look at these risk factors are important because they can really help you to identify adolescents who might be at an elevated risk for depression, and also just inform interventions and preventative strategies for adolescents. So let me walk you through the methods of study 1. So I use data from a longitudinal cohort of adolescent females living in Mpumalanga province in the rural northeast of South Africa, which is highlighted there in the map. And the total sample size was over 2,400, and it had 6 waves over time, annual waves. The primary outcome was depressive symptoms, and that was measured using the CESD, the 20-item measure. And then in this study, I focused on different risk factors at the individual level, interpersonal level, and also at the contextual level, so more structural risk factors. And so that's the list of risk factors that I focus on. So HIV infection, risky sexual behaviors, losing a parent, lack of parental involvement, intimate partner violence or IPV, poverty, which was measured using consumption data, and it was defined as living below the $1.90 per day in international dollars, and then whether the adolescent experienced any episode of food insecurity. And then to assess the effect of risk factors on depression, I used a two-way fixed effects model. And then this table shows the baseline characteristics of the study participants. So you see that median age was 15 years old. Participants had on average 8.4 years of schooling. And around over a third actually had repeated a school grade. And then if we go down to the household characteristics, we see that the median household size was 6 individuals, and more than a third of the participants' parents had no formal education. And then this table shows the point prevalence of high depressive symptoms across all 6 waves. And this was using the cutoff of 16 in the CESD. And I've put it here in bold so that you see it a bit more clearly. And so we found that average prevalence of depressive symptoms was actually quite high. So you see that the highest was in year 2 with 35.2% of the sample above the cutoff, and prevalence did go down over time. If you average all 6 waves, the average prevalence was 25.2. And then you see that more than half of the sample was depressed on at least one of the time points, and then 18% were depressed on at least 3 time points. And just to put things a little bit more into perspective so that you have a bit of a benchmark, if one looks at the prevalence of the depressive symptoms using NIDS, so this National Income Dynamics Study, which is the first nationally representative panel survey that was conducted in South Africa. So if you use data from NIDS, you look at only adolescent women in this age range that I'm looking at, and only those that are living in the area that I'm interested in, so between Mpumalanga and Limpopo, the prevalence there of depressive symptoms is 13%. So overall, we find a much higher prevalence of high depressive symptoms in Mpumalanga province than what we see in the NIDS data. Okay. So here are the results for the study number 1. And in this paper, I ran 2 models. So I first used the depression score as a continuous variable, and then I ran another one using the cutoff of 16. So I create a binary variable, which I refer to as high depressive symptoms. And the variable equals to 1 if the participants scored a 16 or above in the CESD, or 0 if they were below the cutoff. So here I'm only showing you the model using these binary variables. I'm not showing you the continuous one. And for both of these models, I control for a range of variables that we know or are known to predict depression. So age, level of education, employment status, and then a household asset index to measure socioeconomic outcomes. So things like the house, it's basically constructed on information on the housing characteristics, sanitation, and access to goods and services. And the key thing really to look at here is on the odds ratio is basically whether it is significantly different from 1. So an odds ratio higher than 1 means that that particular risk factor is associated with more depressive symptoms. An odds ratio lower than 1, it means that that risk factor is associated with less depressive symptoms. And then if the confidence interval includes 1, it basically means that we find no association, just to make sure that everyone understands. And so basically, what did we find? So overall, if you see in the table, we find that engaging in risky sexual behavior, so things like having unsafe sex and having multiple partners, experiencing IPV, and being food insecure, so going through an episode of food insecurity, was associated with a statistically significant increase in depression. And the largest effect size we see is for IPV, so for intimate partner violence. We also find that higher parental involvement here was protective against depression. So it was actually associated with a decreased probability of being depressed. And then we don't find any association with the other risk factors that you see here in the table. One other thing that I did was to explore whether the risk factors, the effect of these risk factors on depression dissipate over time. So basically, I looked at whether an individual that experienced IPV and how long did it take them to go back to the levels of depression prior to experiencing that event of IPV. And so, for example, just sticking to the IPV risk factor, I found that it took an adolescent 3 years to go back to the levels of depression they had before experiencing that event. So overall, it's not only that risk factors have a significant effect on depression, but it's also the case that they have a persistent effects on depression over time. So let me close this study one with some main key takeaways. So first, what I've shown you is that our results suggest that there's a very high burden of depression in low resource settings. I find that there's very significant and persistent effects of risk factors on depression. And then many of these factors actually, so things like food insecurity and exposure to violence, we know that they are quite common in many low resource settings. And so this basically means that there's a higher share of the population that might be at risk of developing depression. And I guess while they are common, many of these factors are modifiable. So you can actually target many of these risk factors through interventions. So these results could be actually translated into some more universal preventative intervention strategies. So for example, things like interventions to prevent IPV or interventions that provide information about safe sex practices have shown promising results. Okay, so now let's move on to the next study, which was the systematic review and the meta-analysis. So that was study number 3. And so the main research question here is, what is the current knowledge of the effect of depressive symptoms on risky behaviors among adolescents living in low and middle income countries? So the objective basically was to identify and systematically review all of the literature that was reporting on this specific association. And this systematic review and meta-analysis was published in May last year in JCAP, and it is co-authored with Lucy Desborough, who's a trainee clinical psychologist at the NHS Foundation Trust, with Professor Alan Stein and Professor Andrea Cipriani, who are both based at the Department of Psychiatry here at Oxford. And unfortunately, actually, I couldn't afford to pay the open access fees. But if anyone is interested in reading the study, please do email me and I'll send you a PDF. So let me go through the methods of this study. So we followed the PRISMA guidelines, and we also registered the protocol in Prospero before conducting any of the searches. We searched 15 different databases for studies that were published and not published, and also included data from longitudinal cohort studies that recruited adolescents. We focused on 2 primary studies, risky sexual behaviors and substance use. And then as part of our secondary outcomes, we included studies that measured delinquency, risky behavior in school, self-harm, and suicidal behavior. And then as part of our inclusion criteria, so we included cohort and case control studies that recruited adolescents aged 10 to 24 years old that used validated screening tools to measure depression and risky behaviors, and also that controlled for risky behaviors at baseline and also important confounders like sex, age, and socioeconomic status. So here are the results for the meta-analysis. So with the search, we got a total of 31,000 potential studies in the systematic search. Luckily, 4.5 were duplicates, but that still left us quite a long number of, big number of articles to review. And following the guidelines, Lucy and I independently screened all of the potentially eligible studies. So in the first screening phase, we read over 26,500 title and abstracts. And then after reading them, we excluded over 90% of those studies. And then in the second phase, we read 701 full texts, and again excluded around 95% of them and recorded a reason. So here are some of the reasons for why we excluded some of these studies. And after a lot of reading and a lot of self-isolation, we included a total of 33 studies in the systematic review, of which 30 of those were part of the meta-analysis. So let me just jump straight to the results. So pulling all of the data together from all of the different studies, we got a total of almost 36,000 adolescents living in 17 different low and middle income countries. So it was 5 from Africa, 7 from Asia, and then 5 from Latin America and the Caribbean. So what did we find? So this is the forest plot that summarizes all of the studies that reported an association between depressive symptoms and risky sexual behaviors. And let me briefly explain how to read this forest plot. So here on the column on the left, you see all of the included studies along with the year of publication. Here on the column of odds ratio, so you see the results, the study results, so the odds ratio along with the confidence interval. And you can also see this in the box, so the gray box here along with the confidence interval. And basically here, the longer the lines, the wider the confidence interval, so the less reliable the study results. In the last column here, you see the weight of each study, and so that indicates the influence that each study had on the pooled result. And here on the very last row in green, you see the pooled odds ratio along with the confidence interval, and you can also see this in the diamond. And so basically, as I mentioned before, the key thing to look at is whether the odds ratio is significantly different from 1. So an odds ratio higher than 1, which would be around here, means that the depressive symptoms are associated with more risky behaviors. And then an odds ratio lower than 1 means that depressive symptoms are associated with lower risky behaviors. And then the vertical line at 1 is the line of no association. So there's no statistically significant difference between the depressed and non-depressed in terms of how likely is it that they engage in risky behaviors. So what did we find? So here the pooled odds ratio showed that adolescents with depressive symptoms are more likely to engage in risky sexual behaviors compared to non-depressed adolescents. And so the adjusted odds ratio was 1.29. So put differently, there's almost a 30% increase in the odds of engaging in risky sexual behaviors given depression. So that was the first primary outcome, risky sexual behaviors. And this is the forest plot for substance use, the other primary outcome. And here, the pooled odds ratio was 176, so implying that adolescents with depressive symptoms were more likely to engage in substance use compared to non-depressed adolescents. And so again, it's almost an 80% increase in the odds of engaging in substance use given depression. And the results from the secondary outcomes show very similar patterns. So we find higher delinquency, higher self-harm, higher suicidal behavior among depressed adolescents compared to non-depressed adolescents. So here are the main takeaways from the systematic review and meta-analysis from this study number 3. So first, we find that adolescents in low and middle income countries are more likely to engage in risky behaviors compared to non-depressed adolescents. And these findings are consistent with the evidence from high income countries. And then I guess the interesting part is that there are several mechanisms that could help explain these results. So there's, for example, one view, which is sometimes referred to as the self-medication hypothesis, which suggests that adolescents with depression might engage in risky behaviors, such as substance use, as a way to really seek relief from their symptoms or even to experience emotions. That's one view. There's another view that says, that I mentioned at the beginning of the presentation, which basically says that because depression is known to affect our ability to exercise executive function, it could maybe well be that this impairments in executive function may make an adolescent more prone to engage in risky behaviors. And this is the hypothesis that I explore in the next chapter of my thesis. Okay, so now I've presented you results from study number 1 and 3, and then let me now close up with the highlights of the last study, that I'm working on now. So this last chapter really takes into account all of the things that I've learned from the previous chapters and starts to think about ways in which we could develop interventions that are scalable, that are feasible, effective, and safe for adolescents with depression. And just to say that this is a very large study with many countries, institutions, and people involved from very different disciplines. So it's brought together psychiatrists, psychologists, neuroscientists, development economists. So Catherine was saying it at the beginning, across, I think it's around 10 different institutions around South Africa, Uganda, UK, and the US. So yeah, so overall, it's a very interesting environment to work in, and this is part of a really big collaboration. So why do a digital intervention? Well, first, because we know that there's a large treatment gap in many low resource settings. So the bar chart here shows the annual government mental health expenditure by country income group. So we have here low income country all the way to high income countries on the very right. And in general, you see that low and middle income countries spend very little, or spending levels are quite low. And it's actually particularly striking to see low income countries that spend as low as 2 cents per person per year. So this means that few adolescents get access to treatment. Some of the papers actually suggest that less than 5% receive an adequate treatment in many low and middle income countries. Second, there has been a large growth in access to phones in recent years. So although there are still many gaps in mobile and internet connectivity, phone and internet access in general has spread rapidly worldwide, as you can see here in the Our World in Data chart. And third, even in contexts where adolescent mental health services are available, there's some stigma or lack of mental health awareness that could also prevent or stop adolescents from seeking care. And so digital interventions may help to overcome this barrier. And finally, and while there has been a significant increase of digital interventions in recent years, many of these digital platforms tend to suffer from very low uptake or are not culturally appropriate. So, and they often really lack the sufficient rigor to know whether they're effective and safe. And so the objective of this study was to develop a smartphone app that delivers behavioral activation. And so why rely on behavioral activation? First, because it's been shown to be an effective psychological therapy for adolescent depression. Second, because behavioral activation is relatively simple to explain and deliver, so it does not require extensive training or complex skills from the therapist, so it can actually be delivered by lay counselors. It is also less costly to deliver than CBT, than cognitive behavioral therapy. Third, behavioral activation can be delivered via online programs with very minimal support from lay counselors. And finally, while most of the evidence from behavioral activation comes from high-income countries, recent studies, so one conducted in India, another one in Indonesia, have shown actually that behavioral activation can be effectively adapted for use in low-resource contexts and with diverse cultural settings. So in this study, we developed a smartphone app called Kuamsha, which means activate in Swahili, and it delivers behavioral activation. And the app is supported by 20-minute weekly phone calls from peer mentors who are basically trained lay workers with a very similar background to our target participants. And the objective of this study is to determine the feasibility and acceptability of the intervention, and also to provide some evidence on the initial efficacy that the intervention has on depressive symptoms. So how did we develop the app? So we used a user-centered and participatory design, and this was to make sure that the app was locally and culturally relevant, but it was also that it was easy and engaging to use. And so to do this, we conducted focus groups, in-depth interviews, workshops, user testing experiences with adolescents mainly, but also caregivers, local healthcare providers, educators, and community leaders from South Africa and Uganda. And in total, more than 150 participants were involved in the development process. So what does the app include? So basically, drawing on the findings from the formative work, we developed the app using a narrative game design. And this app is basically teaches the principles of behavioral activation to the adolescent through an engaging story. So the app has two different stories, one called the football match and the other one called the song context. And each story is split into different modules, or how we call it, episodes. And so this narrative design walks the user through a story, and it also allows them to make choices along the way. And so these choices affect the outcome of the future interactions, which is also a way for them to know what the consequences of their actions are. And to increase engagement, we included some game design elements. So the user can personalize their own character. They also get points along the way. And at the beginning of the app journey, the participant is asked to think of a goal that they want to work over the 10 weeks of the intervention. And so, for example, adolescents could try to learn a new skill, make new friends, or improve relationship with someone. They're also asked to schedule weekly activities to really practice the skills that they learn through the different episodes. And then there's mood monitoring. So the participant is asked to monitor their mood at very different stages, different points in the app. And they also get feedback on how their mood progresses over time. These are other components that the app includes. So Quamsha is password protected. And this was something that was really raised during the formative work, because phone sharing is something that is very common. So we wanted to make sure that all of the information was kept private. So every time the user enters the app, they have to enter a password. It also includes, Quamsha also includes an emergency number for the adolescents to call if they're feeling extremely sad or thinking of hurting themselves. The app is available in different languages, since we also have different settings. And then the user gets reminded by notifications on on the weekly activities that they scheduled, so for them to do it, but also for them to report whether they've done them or not. And they get points every time they do. So the study is being conducted currently in two different study sites, so South Africa and in Uganda, and it's conducted with two different study designs and also with two different study populations. So in South Africa, the study site is being conducted in Mpumalanga province, and I think Kathy Khan is also part of this call, so she's the co-PI. They're running the study on site. And the adolescents are aged 15 to 19. And they're all adolescents that have scored above 5 in the PHQ. So they're from mild to moderately severely depressed in the PHQ. And we aim to recruit a total of 200 adolescents, and 100 of them will receive the intervention app and 100 of them receive the control app. And then the other study site is in Wakiso district, which is very close to Entebbe. And this is a smaller feasibility study with 30 adolescents from the general population, so not necessarily depressed. And here in this study, everyone gets the intervention app. So everyone gets Quamsha, there's no control group. And both of these studies are currently in the field. So we expect to have some preliminary results late this summer, so in some months. Okay, so 3 minutes to go. So basically, let me go back to the initial diagram that I show you and make a very quick summary of the things that I went through today. So in study one of my thesis, I find very high prevalence of depressive symptoms and significant and persistent effects of risk factors on depression. In study number 3, the meta-analysis, I found that adolescents with depression are more likely to engage in risky behaviors. And then finally, in study 6 of my thesis, I describe the development of the app-based intervention that is being constructed with adolescents in Uganda and in South Africa. And as I mentioned, so we're now measuring or exploring the feasibility and acceptability of the intervention. So hopefully I can come back in some months to present the results from this study. So thanks so much for everyone for listening, and to my supervisors, Professor Allenstein and Professor Stefan Derkon. and to my founder, La Fundación Rafael del Pino. And I'm putting here the contact details in case someone has any questions or wants to continue the discussion. Thanks so much.
Oh, thanks so much, Julia. I mean, that was such an amazing presentation. I think your PhD papers have really contributed to the lack of knowledge in low middle income countries on mental health and risky behaviors. Yeah, really exciting. And I think we've all taken notes of those papers because there's a few PhD students on the line doing kind of some similar work, which I'm sure will be helpful for them. If you're able to unshare your screen, we can then open for questions. We can see a few more people. Any questions from the floor at this time? If not, I will start while we're waiting for people to have some. So I think I really like the app that you guys have developed. I think it's really nice how you've used sort of human-centered design kind of work and really participatory research. A few of us on the line have worked with the WHO on a chatbot using the STARS intervention. And we had some challenges, and I'm just wondering whether you had similar ones where the adolescents themselves would have a phone, but some of the issues about data was an issue in the sharing of phones, but also the app itself, is it data heavy? So we had to use we were trying to use Facebook Lite or Facebook to deliver the intervention via chatbot because it was quite light in terms of data. And also even if the app, if it takes up a lot of space, was also an issue. Have you experienced any of that in your work?
Yes. And that was a thing that was really raised quite a lot of times in the formative work because data, both in South Africa and in Uganda, is actually quite expensive. So the way we actually designed, so we worked with some app developers in South Africa, and they were well aware of the limitations. So what they did actually is that they developed the app in a way that you could play it offline. So you don't actually need data to use the app, which was really useful. In any case, we do see, for the intervention, we are sending regular data and we've tried different configurations. So at the beginning, we're like, let's just send 1 gigabyte at the beginning and let's just see. We have seen that actually is much better to, as an economist, consumption smoothing is a thing. So you want to actually sparse how much and how often you send the data. We are seeing that is a challenge going forward in terms of scalability. But the fact that the app is offline mode actually has helped quite a lot. So we don't actually need them to have access to data to try it out. So that's a big win.
Yeah, that would make a huge difference, I suppose. Right. Wonderful. Any other questions? I saw your hand is up. I'll just check the chat.
Yeah, hi, Julia. Thanks very much for a great presentation. Really, really interesting to hear about your work. I just wanted to ask about your first study, the longitudinal study looking at risk factors associated with depression. And apologies if I missed it, but can you say a little bit more about the time association? So was the depression outcome measured at every time point, or was it measured at subsequent years, and at which point were the risk factors measured?
Yeah.
So what was the sort of time lapse between exposure to the risk factor and the depression outcome?
Right. So that's so all of the depressive symptoms and risk factors were measured across all 6 waves. So that was the when they were asked. In terms of temporal precedence, which is, I guess, what you're asking, because you want to make sure that you said that you're exposed to the risk factor first and then depression. So all of the risk factors were asked about the past year, and the CESD was asked in the past 2 weeks. So that's how I kind of set the fact that the risk factor was exposed first. When I do this thing that I mentioned briefly on the dynamics over time, I do actually make sure that I see, so once you're exposed to the risk factor, what effect does that have on your depressive score, right when you're exposed to it, but also 1 or 2 or 3 years time post. So I do try to play with that time dynamic to make sure that I set the temporal precedence between first exposure and then outcome.
Okay, that sounds great. It'd be interesting to explore things the other way around, and look at the extent to which depression predicts subsequent risk factors. And maybe that's for your postdoc.
Yeah.
But it'd be really interesting to look at the association both directions over time.
That's a good point. Yeah.
Yeah.
Wow. And also the interaction among risk factors, right? So that's,
exactly,
the fact that you're exposed to IPV could also make you more likely to be exposed to poverty. So these interactions, you could go really crazy with the different things. But yes, I agree that looking at the bidirectional relationship is also something interesting to look at things.
Thank you.
Tandy has a quick question, and then we'll go to Diane. She wanted to know, can you say a little bit more about the particular behavioral activation activities that are encouraged, or are these participant specific?
Yes. So in every single episode of each story, there's specific focus to different principles of behavioral activation. So there's things like problem solving, sleep hygiene. So they are kind of directed to specific activities weekly, but we let the participant actually select which type of weekly activity they want to work on. And that is actually something that I've seen that the peer mentors, so these lay counselors that I mentioned, that call them every week, have helped quite a lot, because we do see that adolescents at first, they try to choose weekly activities that maybe are not feasible or they're too much for them. So the peer mentors in 15, 20 minutes, they have to make sure that the activities actually are something that is meaningful to them, that they can actually do. But so it's different per participant, and the peer mentors try to redirect in a way that it's relevant to this goal that I mentioned that they want to work on in the 10 weeks that the intervention lasts.
And I suppose when it comes to behavioral activation, it's about things that make you relax, but also things that make you feel proud. So behavioral activation often has those two sides.
Yeah.
Diane.
Thanks. That was a wonderful presentation, Julia. I don't know you, but really, I gained so much from it. It was so interesting. There were just two things I wanted to ask. I came on a bit late because I had another commitment. So you might have already presented this. But did you find any gender differences? And I'm specifically saying gender rather than sex differences. In other words, socially determined sort of differences between depression in girls, boys, men, young men, young women. And then the other thing that I was interested in is just because I've been involved in studies where this has been difficult, if via the app there is a sort of an emergency, in other words, somebody really needs help. Have you had any instances of that yet? And do you find that you're able to deal with that adequately, sort of remotely? Thanks.
Yeah, very good questions, Diane. Thanks so much. So on the gender differences, so the very first study, the cohort study that I use is only adolescent females. So I'm not able to assess any of the difference there. In the meta-analysis, I do look, because we do get very high heterogeneity in the study. So I do look at different subgroups. And so one of the subgroups that I look at is whether the effects are different depending on males and females. And that's the only data I have. So I don't have any data on gender. So I just have it on sex, so that you know. And there actually what I find is I do find a difference in the association. So females seem to have a much higher odds ratio in terms of the likelihood of engaging in risky sexual behaviors compared to males. So the association seems to be stronger among females. And I don't find any difference in substance use when I do that same subgroup. So there's no statistically significant difference between males and females. So that's on the gender question. And then on the risk management, you raise a very important question. And so there's different routes through which we get flagged whether there's a case that needs to be referred. So the first one is through the app. There's the mood monitoring. So if we see that some participant keeps on having very low moods, that would raise some sort of flag. There's there's an emergency button that I think I mentioned, where if someone actually calls that phone number, we get basically a risk flag so that we have to follow up with them. They can also be referred, or we can also know whether some participant might be at risk through the peer mentor calls. So there is a very standardized procedure and protocol in case some participant mentions suicidal intentions or ideation. And so that's something that is also something that the peer mentors have been very heavily trained to know when to refer. So we have a very structured protocol, so risk management protocol, to know in which cases has to be referred to the clinical psychologist of the study, which is there in place full time. And then we also send them regular symptom monitoring. So we send them to their phone number, the PHQ, for them to answer. And so if they say yes to the 9th item of the PHQ, so the suicidal ideation item, or if they're in the severe range, they also get referred. So there's many different routes through which a participant could get flagged. And so so hopefully we try to manage them in the best possible way.
Thanks, that's very helpful. Thank you.
We have a question from Ranga. Sorry, I missed it at the very beginning. For study 1, what were the major reasons for that huge dropout in the cohorts in year 4?
Yes, that's something that I struggled with. So basically how this cohort study was designed was, it was part of a conditional cash transfer where adolescent females were given a cash transfer conditional on them attending school. And so they recruited participants from grade 8 to 11 and followed them for 6 years. And so basically what happened is that by design, some adolescents had graduated from school, so they no longer were part of this intervention. So the wave 4 of participants were not followed up because they were no longer they were not given cash. For the last 2 waves, they tried to get as many participants as possible. And so that's when I tried to, that's when we get a higher sample size. I did all sorts of attrition bias analysis. So I looked at all the different things that were measured, and I do not see any difference or any attrition bias, but it is true that that's a big limitation that I put very prominently in the limitation sections of my paper.
Good. Thanks. And we have one from Leslie while he's still here. The generality and interdisciplinarity of it reminds me of a key tension in global mental health. We talk a lot about cultural context and its importance, but on the other hand, this helpful work is across quite a wide range of contexts. Is culture and local context unimportant? Or are we talking at a high level of generality? Or is it culture and then very local just too expensive? Or is it culture and then very local just too expensive? I may have to rush off, but I'd love to know what your thoughts. Yeah, I guess it is that, that discussion about global mental health.
Yes. Let me just read it again because it's a long one. Yes, I mean, I think there was actually, I think maybe even Tandy, I'm part of the CPMH chat, and I think someone had shared this comment by Bikram Patel on how much are we focusing on adapting interventions and trying to, in a way, kind of reinvent the wheel so that we make sure that it's all adapted to the context, and how much are we kind of shooting ourselves in the foot in terms of like more scalability going forward. So yes, it is expensive to run this very local type of interventions. Our hope is that this is just a start, and the idea of like telling stories, and through these stories talking about principles of behavioral activation is something that could be adapted and expanded. You can have stories that are more relevant to one context or the other. So I think that's the beauty of the intervention, that it could potentially be scalable to be much more generalizable across different contexts. But I totally agree with Leslie's point. Like it is quite a contentious topic in global mental health area. Yes.
I quite like how in this case it's kind of self-guided, it's guided self-help also. So it's not, you're not leaving them to their own devices. There is that kind of community health worker from those local areas that are also kind of giving input, which is great. Yeah. Crick.
So also just to add a bit and respond to Leslie's question, I think there was a huge amount of validation work of the concept of depression in the local adolescent community in Mpumalanga province in preparation for developing this intervention. So all of that work that Julia described for me is a really important part of cultural adaptation and culture in the broadest sense of how adolescents live their lives, what they choose to value, the norms within that setting. A lot of those issues, I think, were encountered in the process of developing this app. And so, for example, all the examples around what are behavioral activation tasks, I think we're really trying to make that as locally relevant as possible. I mean, is that right, Julia, would you say?
Yes, I mean, it was really funny because we had a lot of ideas about how we thought the app could look. And then it was very much drawn from all of the findings from the formative work. So many things on how, like, what sort of resources do they rely on, people that, so one of the things that it was interesting to see is that they were very interested in hearing stories of people that had gone through different challenges, and then how did they manage to kind of overcome those barriers. And that's how we came with the idea of like, tell a story about someone that might be very similar to them in their context, that goes through very similar things. So one of the stories, the song context, is this we heard a lot, which was also interesting for me, given what my PhD was focused on. So we heard a lot about adolescents going to taverns, drinking alcohol, drugs, all of the peer pressure, which is very much related to what I was interested in terms of depression and risky behaviors. So the story of the song Context is the story of an adolescent that has to decide whether to go to the tavern, what the consequences of that are, how the peer pressure kind of helps you. So in a way, it was all drawn from the formative work, and we took a lot of time actually to develop this app. So yeah, it was all drawn from these findings and from this adaptation and co-construction that we did with adolescents in South Africa and in Uganda.
Thanks, Julia. And I think this co-creation of these interventions is the way, isn't it? We're kind of are taking that participatory action, human-centered design.
Yeah.
Diane, do you have one last question?
Thanks. Sorry that I'm asking too many questions. The one thing that I just wanted to ask you is, and maybe you covered this, but whether there were age differences, because it's, it goes, I can't remember, it's from 13 up to
20.
Yeah. So I mean, what a 13-year-old or 14-year-old might be feeling might be very different to an older adolescent. So I was just wondering, did you find differences? And I was thinking in terms of also interventions to sort of look at when does depression start to perhaps increase, although we might not know why. And then the other thing is also in the app, do you use the same stories and exercises for all age groups, or is it adapted to different age groups?
Yes. Thanks so much, Dan. Very good questions. So on the age differences, I did some heterogeneity analysis for the study number 1 to look at whether the effect of risk factors on depression was different across different age groups. And I do see, I don't have it on the top of my head, but I do remember that, for example, HIV was something that if you did get it quite young, it did have an effect on depression later on versus getting it relatively older. And it's true that 13 to 20, it's a very big range of especially during adolescence, where so much happens during this time. And I totally agree with you that intervention should be take care of this. So I remember actually part of this same study, I looked at whether there are any age differences on how they spent the cash transfer that they were giving as part of this intervention. And you can see actually that some of the younger adolescent, and this is all adolescent females, that many of the younger ones who arguably were more exposed to peer pressure, or they were more sensitive to peer rejection, they spent much more of their cash transfer on makeup. And they said that it was because they wanted to fit in and that they didn't want to feel rejected. And that was different to the older adolescents that maybe spent it more in household chores and food for their own families or for their own babies. So there was an interesting, as an economist, an interesting way to look at how do people actually spend their own money depending on their age. So that for me was like so a very good point on like, do we actually develop the same intervention across different age ranges, especially when we know that so much happens during adolescence. On the intervention, so I actually didn't say this. So the intervention in South Africa and Uganda, we're recruiting adolescents aged 15 to 19. So it's a relatively short range, so a smaller range of adolescents. And that was precisely because of that, because I don't think you can make the same app for 13 years old versus a 19-year-old. So we decided to shorten the age range that we were interested in.
No, thanks. That makes sense. And it would be very complicated.
Yes.
I mean, it's a complicated study as it is, and to make a whole lot of different kinds of apps would make it that much more complicated. But thanks very much.
Yeah, of course. Thanks so much.
All right, we've come to the end. Thank you, everyone. Thank you, Julia, for everything, and thank you for participating and all your wonderful questions. This will be posted online on our CPMH website, and we're looking forward to seeing you at the next CPMH seminar. Thanks.
Great. Thanks so much, everyone. Very nice to be here. Bye.
Thank you. Bye.
Bye.